step toward long-lasting keratoplasty and medically challenging corneal grafts. There is no financial interest beyond this presentation. The history of penetrating keratoplasty is almost 100 years old, starting with Elching Pill in Prague and later by Theodor Thomas in the United Kingdom. There have been significant advances in the instrumentation, suture material, operating microscopes, medications, and surgical techniques used in keratoplasty. Keratoplasty have been improved through the recent years from the traditional and the old methods of regaining visual function of the eye from the full thickness, that's to say penetrating keratoplasty, toward the new and evolving methods of tissue choosing and implantation, passing from the lamellar to Millis procedures, deep lamellar, manual, and then DALK with the Anwar's big bubble method. As we see here, the progression of keratoplasty or the full thickness, then lamellar keratoplasty, and then to the deep anterior lamellar. Also, the endothelial keratoplasty have been such improvement. However, it is important that the surgeon is clear on the reason for their adopting a particular technique with the patient. So the traditional way of thinking, what is my decision? And what I'm looking for progression of better vision and safe keratoplasty, what are the risks against my benefits? So sometimes, for example, if you choose penetrating keratoplasty in severe, challenging, angry eye and only eye, and you have to face the problems of early rejection, or sometimes thin cornea, and you have to deal with the challenges of suturing. So if nothing goes right, so you have to go on the other side. Always there is another way. Appropriate graft tissue for implantation on the recipient eye on regard to the endothelial count, hexagonality, presence of polymegarism, pleomorphism, what we call it endothelial morphometric parameters, as very important. And in regard for what we call the anterior keratoplasty, that is disease of the anterior stroma, superficial stroma, or even the Bowman's layer diseases, the choice of the donor tissue is of not in less importance than the choice of full thickness keratoplasty. As some literatures say, time of the death to preservation interval, what we call it the DP time of the selected graft, if more than 6 hours, for example, is especially important in causation of post-operative epithelial sloughing in grafted tissue. And there are many factors to deal with in case we plan to proceed to a safe corneal graft. The important two factors are, the first is the surgeon factors, and the second is patient factors. The surgeon factors, first of all, is the centration of a graft. It's very important to give a good chance for equalization and be away from the peripheral corneal vascular vessels. And the second factor is the trephine size to vertical limbal size. At least, as we know, must be at least 2 millimeters or more in the normal cases. Suturing procedure is very important to choose, especially in peripheral vascularization, as to avoid the continuous sutures like TURG or anti-TURG or no-TURG sutures in case of corneal vascularization. And the technique selected, which is full thickness of lamellar keratoplasty or deep interlamellar keratoplasty, in such case to avoid the complications that may happen. As we see here, the multiple suture materials. And as we see here, with the continuous sutures, we can see the inflammations that can happen or reaction that can happen. We have to avoid. And in case of, for example, for 6 months or so, it's easy to remove. But if in the early months of post-operative, is very important. As we see here, after removal, there is quite improvement in the case. The surgical techniques of leaving a posterior ledge compensates for the overcutting and assists in the producing of self-sealing incision. The ledge is created by trephination to over 90% of the corneal depth, preferably to the decimus membrane level of the host button, and then cutting the host button out with the beveled corneal scissors. As we see here, the bottom was be completed by the corneal scissors and left without complete trephination, the penetrating keratoplasty. The patient factors, the patient age is very important. For example, early age, selected younger patients have high degree of immunological reaction against the grafted tissue. And all patients have less aqueous, less tear production that can cause dryness of the eye and can cause persistent epithelial defect and possibly graft complications. Second thing is the status of the limbal tissue. For example, vernal keratoconjunctivitis, spinous corneal vascularizations are very important in such issue. The presence of iridocorneal endothelial adhesions, if are present, so can give a great vicinity of the cornea of the host tissue to be in contact with the grafted tissue that can cause early rejection of this graft. The patient compliance with the medication is very important. Sometimes the instructions are not in the papers and in demonstrations are given for the patient, but the patient is not compliant with the medications. It's a very important issue to deal with. And the financial status of the patient, this is really this is maybe as you're astonished from this point, because in our region, sometimes there is no financial cover or there is no medical insurance in some areas. So, or maybe it's an optional issue. So this is very important to deal with the patient. Can he buy the medications or not? Can he follow the visits for the doctors or not? And geographical location of the patient is very important. As you know, that I'm from Iraq, it's Mediterranean, and there's a very hot climate atmosphere there. So the follow-up must be very important, and sloughing and the frequency of medication is very important to be dealt with. Other factors, patient education and his or her families or her relatives, is very important to deal with the complications, as he can notice any changes in the eye, and changes in the vision, changing congestion or something like that, and how can give the medications to the patients. Present and past ocular history is very important for patients. For example, have 2x penetrating keratoplasty, 3x all keratoplasties or not, previous trap surgeries, dry eye, previous ocular surgery, past medical histories also is very important. For example, patient with renal failure or patient with liver failure or any other problem, he cannot take the steroids or have steroids for the treatment of rejection, or cannot take immune medications to treat with this immune rejection. And the status of the other eye is very important also. As you can see here, for example, this patient with stromal herpes keratitis and with stromal vascularization, I did for him a lamellar keratoplasty with the interrupted sutures, and with the follow-up time, there is any problem he faced. There's another patient with perforated cornea, with melting perforated cornea, and I did for him tectonic grafting, and after that, unfortunately, I have no other picture for the phaco. I did phaco after 1 year. This is another interesting case, really. Patient with vernal keratoconjunctivitis with the scarring of the cornea, and I cannot do for the thinning of the cornea also. I did for him only LK. That is, I maintain the cornea totally apart from epithelium. I remove just the epithelium and put just the corneal graft on the epithelium of this patient, and now he's doing well without any extra risk of rejection. This is another patient with peripheral corneal perforation. Yes, I'm finished. Okay. Take a home message, check the graft for the penetrating or lamellar graft, the status of the sutures, which are the types of suture, continuous and interrupted or combined, and any vascularization around them. And if the graft is eccentric or central, signs of rejection, which may be epithelial, stromal, or endothelial, and the keratic precipitates, of course, and the types of them, AC cells or flare. Thank you for your listening.